Okay, well, good afternoon, everyone, and welcome to the 2022 Network of the National Library of Medicine's virtual symposium on advancing engagement through research. My name is Keith Herzog, and I am part of the NNLM's National Evaluation Center at Northwestern University in Chicago. It is truly my great privilege to introduce our speaker today, Dr. Greg Marcus, who will be talking about digital phenotyping and personal sensing in cardiology and beyond. Dr. Marcus is professor of medicine at the University of California, San Francisco, associate chief of cardiology for research at UCSF Health, and the inaugural endowed professor of atrial fibrillation research. A graduate of UC San Diego as a philosophy major, Dr. Marcus went to medical school at George Washington University. He then went on to complete his internship, residency, and served as chief medical resident at Stanford University. And subsequently, he completed his general cardiology and cardiac electrophysiology fellowships at UCSF. And as part of an NIH-funded career development award, he then completed a master's in advanced studies in clinical research at UCSF. In addition to engaging in an active clinical practice dedicated to the diagnosis and treatment of arrhythmias, including caring for patients in the clinic and hospital, performing catheter ablation procedures and implantations of pacemakers and defibrillators, and training cardiology electrophysiology fellows, Dr. Marcus also has an incredibly active and robust research program. His research is dedicated to understanding the fundamental causes of abnormal heart rhythms, identifying optimal therapeutic approaches for those arrhythmias, understanding the overall health effects of common exposures such as caffeine, alcohol, tobacco smoke, and cannabis, and using technology and wearable sensors to enhance health and the efficiency of patient-oriented research. He is one of the founders and continues to serve as one of the principal investigators of the worldwide internet-based Health eHeart study, as well as the NIH-funded national infrastructure to facilitate mobile health called Eureka. He also runs several ongoing single-center and multi-center randomized prospective trials and oversees a team of investigators, including postdoctoral fellows, clinical research coordinators, statisticians, and data analysts. So 2 final notes. First, this session is being recorded. It will be made available after the symposium for up to 30 days on the symposium website. And after that, all recordings will be transferred to the NNLM YouTube channel for later viewing. Second, please feel free to add questions to the chat, and we will discuss and explore those questions during the Q&A portion. And with that, I welcome Dr. Marcus to the virtual stage to discuss digital phenotyping and personal sensing in cardiology and beyond.
Thanks so much, Keith, and really appreciate the invitation and opportunity to speak to and hopefully with all of you. And I hope to make this relevant in at least a couple of ways. One is to emphasize, as Keith mentioned, this Eureka digital research platform, which we've really designed with the hope that people would make use of it. It is meant to be a resource, and please consider most of what I'm going to share here today as examples of the kind of stuff that can be done using that infrastructure. Also, hopefully people will find this interesting and relevant, as I will touch a bit on some of our recent work related to alcohol and coffee, which are both so ubiquitous. And hopefully my slides will advance. There we go. So here are my disclosures. So when it comes to digital health or mobile health research, there's often a tendency to think about, well, we have this fancy, shiny new gadget, and let's just let's just study that, as opposed to starting with a fundamentally kind of grounded, interesting, relevant research question and viewing gadgets, technology, the internet, mobile apps as tools to help us achieve the truth, to help us discover new and important things. And I favor the latter. And in that same vein, try to encourage really anyone interested in clinical investigation not to feel alienated or excluded from what is sometimes called digital health research, thinking that's only in the arena of those with that expertise, but rather to think about technology, gadgets, mobile apps as tools like you would any other tool, like a statistical test, like the availability of a cohort to conduct your research. So I'm going to share some of our experiences in hopefully effectively leveraging technology to help us answer questions. And I'll start with some examples of research questions that really arose from patients, which are often the most valuable and insightful questions. Then I'll talk about leveraging existing device data in the spirit of kind of an efficient use of resources for analyses. And then similarly, leveraging existing device data for new applications. So something different than the original intent of those devices related to either disease states or changing circumstances. And then finally, I'll share or talk a bit about our Eureka digital research platform, again, really built to facilitate your mobile health-based research. So starting with these patient-centered research questions. So this work was funded by PCORI, the Patient-Centered Outcomes Research Institute, and really did arise from the frequent descriptions of patients with atrial fibrillation, the most common heart arrhythmia, that they would be very interested in identifying triggers for their arrhythmia. And so we performed a survey where we just sent an electronic survey out to our Healthy Heart Study participants who had told us they had AFib. And we asked them, when you have an episode, do you think that it's triggered by some exposure or behavior? And if they said yes, we asked them to describe what the most common triggers were. And the list is here. And the top two were alcohol and caffeine. And these have proven, in my view, to be especially interesting to study for a few reasons. One, because they're so commonly consumed. And it's really interesting doing this research because in speaking with people, you start to realize how there's this kind of tacit or unspoken habit that so many people have that we don't really talk overtly about. And second, I think that research focusing on alcohol and caffeine is especially compelling, given some evidence that there may be some health benefits in certain cases and potentially harms. And these haven't really been formally elucidated. So in terms of alcohol and atrial fibrillation, there have been many now very large prospective epidemiologic studies where they ask participants how much they drink, and then they follow those individuals over time to see, do those that consume more alcohol tend to be more likely to develop atrial fibrillation? And this was a really important meta-analysis, the point estimates at the bottom there, where the conclusion has been, yep, people who drink more seem to be at higher risk for atrial fibrillation. Now, a major limitation of all of those studies, and this is common to the great majority of alcohol studies, is they rely on self-report of alcohol consumption, which, not surprisingly, may not always be accurate and is especially inaccurate among heavier drinkers. So this was in part what motivated a recent study where we fit paroxysmal atrial fibrillation patients with a continuously recording alcohol sensor, as shown on the left there, as well as a continuously recording ECG monitor, a Zeo patch shown on the right. And with the Zeo patch, there's a button that we often ask patients in clinic to press to denote whenever they have symptoms. But in this case, we instructed these participants just to press that button when you have a drink of alcohol. We also obtained blood for this chemical called phosphatidylethanol that is only present in human blood as a result of alcohol consumption or ethanol consumption. It can be thought of as kind of a hemoglobin A1C for heavy alcohol consumption. It's not super sensitive, but is quite specific. And we found that those button presses indeed were validated by that blood test as well as the alcohol sensor. And we did find that consuming alcohol, whether that was determined by that button press or by the alcohol sensor alone, substantially heightened the risk that a discrete atrial fibrillation episode would occur only a few hours later. So one drink was associated with a twofold greater odds of a short-term AFib episode, and more than two drinks, more than a threefold greater odds. And this sort of real-time, continuously recording in ambulatory individuals was really not feasible not that long ago because it requires continuous monitoring. That requires these sorts of wearables. So whereas in the past, we could try to get at this question of, well, is there a relationship between alcohol and atrial fibrillation by just looking at baseline, self-reported answers to questions, and then following over time for an initial diagnosis of the disease. Here, we can address a different research question, which is, does consuming alcohol acutely change or alter or influence the risk that a discrete or given episode is going to occur? And we don't have to rely on self-report. We can use these objective measurements. And I think partly because of the original, a kind of original approach, thanks to these tools, these wearables, we were very fortunate to be quite prominently featured in the New York Times to demonstrate this novel relationship. Now, what about coffee? And really, when we're talking about coffee, we're largely talking about caffeine, although there could be other constituents in coffee that matter. So there's this conventional wisdom that coffee increases the risk for arrhythmias, but there's growing evidence that may not necessarily be true. We performed an analysis using data from the UK Biobank, where we did a conventional sort of analysis. We looked at the answer to the questions people gave at baseline, how much coffee do you drink? And then looked to see what happened to them over time. And interestingly, people who drank more coffee actually exhibited a lower risk of arrhythmias or abnormal heart rhythms, much of that driven by a lower risk of atrial fibrillation. Incidentally, we also did a Mendelian randomization study in the hopes of trying to mitigate the problems with self-report and could not find a heightened risk of arrhythmias with coffee intake. So this and other studies motivated a recent trial that we completed, not yet published. The manuscript I'm about to submit, but I was fortunate to be able to present this as a late-breaking clinical trial at the American Heart Association meeting. So we call this trial or study CRAVE, which stands for Coffee and Real-Time Atrial and Ventricular Ectopy. So we enrolled 100 volunteers. We fit them all with that same Zio patch continuously recording ECG device. We gave them all Fitbits, wrist-worn Fitbits, to record both step counts as well as to quantify sleep. We gave them continuous glucose monitors, given some evidence that coffee drinkers seem to experience a lower risk of diabetes. And then we obtained DNA that we genotyped for caffeine metabolism-related genetic variants. Now, and then we randomly assigned them day to day for 14 days via text message. Go ahead and drink all the coffee you want. And we did encourage caffeinated coffee versus avoid all caffeine today, day to day. Now, a question that often comes up when people first hear about this study or when they were being enrolled is how do you know people were actually following their instructions, that they actually consumed or avoided coffee when you told them to? Now, of course, these are people enrolling in a study. They don't really have a reason to lie. They understand this is part of the deal. And in fact, there were many people that were not able or not willing to participate in the study because they said they could not go a day without their coffee. We also only enrolled people who did tolerate and drink coffee sometimes. So the question is, how do we assess compliance with that randomization assignment? So we had previously demonstrated in this proof of concept study that we could passively monitor the geolocation of individuals, in this case, healthy heart participants that agreed to this. And we employed what we call geofencing. So in this case, when someone crossed a geofence or entered the area of a hospital, that then triggered, they had to be there for at least 4 hours, that then triggered a survey that asked them, did you receive medical care at whatever the hospital was called, St. Mary's Medical Center? And we found that it wasn't perfect, but it was quite accurate in passively and therefore largely continuously monitoring individuals for visits to a publicly known location. And really, this could be theoretically applied to any location in Google Maps. So when you search Google Maps, looking for an ATM, or I'm looking for a gas station, or I'm looking for a liquor store, those could all be pre-specified to trip a geofence. So in Crave, we use this feature to geofence for visits to coffee shops to help us with compliance assessment. We also reimbursed, and we advertise this widely, we reimbursed for all coffee consumed as long as they gave us a date stamped receipt. And we told the participants, doesn't matter whether you're actually supposed to have coffee or not, we're happy, we just want to pay you so that we can collect all the receipts and really assess compliance. The outcomes of this study were primarily daily ectopy counts, premature atrial contractions, premature ventricular contractions. We also looked at other arrhythmias, step counts, sleep duration, and glucose. And I'll just go through some of the main findings. Now, some may ask, who cares about premature atrial contractions, premature ventricular contractions? Why are those relevant? Well, first, they're relevant because we all have them. We put a Zio patch on pretty much anyone. We will find PACs and PVCs. But also, we've learned recently that these are actually clinically relevant. So PACs are actually an incredibly potent predictor of atrial fibrillation. In this study, we found in this prospective cohort, they were more potent than really any other single predictor. There's also growing evidence that PVCs are a risk factor for heart failure. And we know this from the EP lab, that some people with heart failure, frequent PVCs, if we can successfully ablate their PVCs, oftentimes their heart failure or their systolic dysfunction may normalize. So in terms of the people we actually recruited, fairly young, on average about 38, but we had good representation of every decade of life up to the 70s. About a half were female, about a half were non-Hispanic white, and most people on average tended to drink about a coffee drink per day. When we looked at the compliance, it was actually pretty good. It wasn't perfect, but regardless of how we looked at it, so the figure here on the left, each row is a given individual. Blue means they were concordant in terms of what they reported, in terms of what they actually consumed with coffee versus their randomization assignment. Red means there was some discordance. White means they didn't report. Whether we looked at the geofencing or the receipts, most of the time people were following their randomization assignment. And in brief, we found no relationships between coffee consumption and premature atrial contractions. However, we did actually find about 50% more PVCs on days when people were randomly assigned to consume coffee. And based on how many drinks they told us, based on, actually we had them also press the Zio patch as in the alcohol study to denote in real time when they had a drink of coffee, more coffee drinks consumed, more PVCs. Also interestingly, although in intention to treat, so the days randomized to coffee were not associated with differences in supraventricular tachycardia, there was evidence that per real-time drink, there was a lower frequency of SVT, which seems counterintuitive, especially given the PVC findings. But actually, going back to that UK Biobank study, interestingly, if you look at the top, which where there's atrial fibrillation, there's less atrial fibrillation, less SVT, supraventricular tachycardia, among those who consumed more coffee. But at the very bottom, there was actually a trend, so not statistically significant, but the point estimates favored more PVCs among those who consume coffee. So there may be a discordance between the supraventricular arrhythmias and ventricular arrhythmias when it comes to coffee. Okay, coming back to the patient-centered question, and of course, previously I just honed in on alcohol and caffeine, but most of people, even though those were the two most commonly reported triggers, most people describe all kinds of other things. And So the question is, well, how can you study that? Because they're so variable, they're so idiosyncratic to a given individual. And so this idea of trying to hone in on each individual or conduct an N of 1 study is especially amenable to these wearables and current technology. And one example of that is a trial we recently published called the iStop AFib study. So this also was PCORI funded, a lot of input from atrial fibrillation patients. We utilized that survey I described and essentially asked paroxysmal atrial fibrillation patients who were interested in, who thought they had a trigger that they could actually test and were interested in testing, to download a version of the Eureka app. They were then randomized to just track their AFib for about 10 weeks versus to undergo their own customized N of 1 trial. So those randomly assigned to the N of 1 trial would select from a menu of triggers. Then they would be instructed a week at a time, this is your week to test your trigger. You told us that cantaloupe or 2 glasses of red wine or coffee triggered your AFib. Go ahead and test that this week. And then on the off weeks that again were randomly assigned, make sure to avoid your trigger. Remember, you said cantaloupe causes AFib. Don't consume any cantaloupe this week. And then we assessed their quality of life. We provided them all with this AliveCore cardio mobile device that records a single lead ECG and also has a FDA cleared algorithm to call AFib or not. And at the end of the N of 1 study, we provided this illustration where we showed them, here's when we told you in yellow to test your trigger, and in gray when to avoid your trigger, and here's how the AFib that you exhibited. And then there was an R program that ran in the background that gave them a probability that whatever their selected trigger was, that it actually influenced their AFib. Interestingly, we found no difference in quality of life, but the people randomly assigned to the N of 1 trigger testing did exhibit less AFib after that trigger testing compared to the tracking only, suggesting that maybe they did learn something useful regarding their arrhythmia. And then when we looked at, okay, well, what triggers actually were associated with AFib versus not? Interestingly, consistent with the literature in the past on alcohol, alcohol came out as associated with a heightened risk of discrete AFib episodes, whereas caffeine, interestingly, also consistent with the literature, did not come out as a risk factor. Okay, moving from patient-centered questions now to leveraging existing device data for analyses, which again can be incredibly efficient, and I would recommend to especially junior investigators. If you're ever working with a device or a company that has an app, keep in mind that company has all kinds of data from that app, and oftentimes there can be a nice win-win because where the company is interested in getting their name out there, the fact they have this technology out there, and you can perform often very novel analyses. So I'll give a couple of examples. So one is a company called Backtrack that makes this consumer-facing Bluetooth-enabled breathalyzer device. I actually don't really know why people purchase this, but presumably they want to check before they go driving. And so we were able to get data from this company from over a couple of years, tens of thousands of individuals, and Kirsten Aschbacher, the first author of this paper, applied a machine learning algorithm using all of the data available from the app, which is incredibly rich, including geolocation, some baseline demographics, and then how often they use the device, when they use the device, what the breath alcohol concentrations actually were, and both trained and then validated this model that could predict when someone was going to hit 0.08% or above the legal driving limit. The idea being that that could then potentially inform messaging to the individual, be careful, you're about to exceed the legal driving limit. We use the same data to help us answer a research question about AFib, similar to what I described before among the densely phenotyped, relatively small number of paroxysmal AFib patients. The question is, well, what about on a population level? Does drinking alcohol acutely raise the healthcare utilization for AFib for society in general? And so we took those breathalyzer measurements over a couple of years from tens of thousands of people, and we identified the days of the year when the breath alcohol concentration was highest. And then we correlated that with nationally recognized events. Then we looked at 11 years of data from millions of records, essentially all emergency department visits to California, and looked at those same dates to test the hypothesis that the dates with the highest blood alcohol concentration in this completely separate cohort of people who happen to be using these breathalyzers would line up with the dates when there was more visits in the ER for AFib. And it wasn't perfect. The events that were empirically, importantly, empirically derived from that breath alcohol data. We didn't just come up with these. They were on average, not in every case, but on average associated with more ER visits for atrial fibrillation, providing this kind of proof of concept that this occurs. The other thing we could do with these data that we could not do with the again, densely phenotyped data with wearable sensors is to ask the question, does acute alcohol lead to a first episode of AFib? Of course, to conduct the sort of research I described before, where we're enrolling paroxysmal AFib patients, we have to know that they're going to be at risk for recurrent episodes. You can't really capture, does a discrete alcohol binge drinking event correlate with a first diagnosis of AFib? But with these data, we were actually able to exclude everyone with any previous diagnosis of AFib, and did indeed show that people coming into the ER for their very first time for AFib correlated with these events, which we used as instrumental variables essentially, that were associated with more drinking per that Bluetooth-enabled breathalyzer. Okay, then one can think about leveraging existing device data for new applications. So this device was intended for people with diabetes, but we use the continuous glucose monitor, for example, in CRAVE to help us answer that question. One example here is a study we did now several years ago, where this is before Apple had the idea to see if their watch could detect AFib. And so there was no EKG feature, but there was the PPG feature, the photoplethysmography light sensor-based feature to detect heart rate. Fitbit has the same thing. Samsung now has the same thing. And the question was, well, if you can detect the heart rate, then you can detect the variability of the heart rate. And atrial fibrillation classically exhibits this irregular pulse. So can we infer atrial fibrillation from the pattern of the heart rate data? So we worked with some data scientists that subsequently spun out a company called Cardiogram. They worked with us in the Healthy Heart Study. And we demonstrated that with the Apple Watch, we could indeed distinguish atrial fibrillation from normal rhythm. And this was using a machine learning algorithm that was trained on thousands of individuals in the Healthy Heart Study. We validated it in a very carefully controlled setting. So patients undergoing cardioversion, where we would put the Apple Watch on, record, we knew at that time they had atrial fibrillation. We would shock them for clinical purposes to get them in normal rhythm, re-record in sinus rhythm, and the C statistic was 0.97. So very, very high performance of the machine learning algorithm there. Then we applied it to a separate cohort of ambulatory individuals wearing Apple Watches in the Healthy Heart Study population, and the accuracy really plummeted. The C statistic was still reasonable as far as they're showing there was an association, 0.72, but certainly not acceptable from a screening standpoint. And then after this, as hopefully many of you know, there's been kind of an explosion of interest in using smartwatches to detect atrial fibrillation, and that's now actually being done. I wouldn't call it in clinical practice, but rather in this relationship directly between industry and the consumer, which is very interesting, and still some consternation regarding possible false positives and precisely what to do with that information and how to optimize it, and happy to discuss that either when I'm done speaking here or offline if that's of interest. So some other examples of, again, using device data to answer other research questions. So we were interested in the Bay Area where we were really inundated with toxic smoke from the wildfires. Unfortunately, this has happened now more than once, and recognized that people who didn't live in the area or in California may not have fully appreciated how oppressive that was. It wasn't simply a matter of the tragedy of the wildfires or the danger of risking, losing one's life directly from the wildfire or having their property destroyed, but how this was affecting millions of people that were told, you got to stay inside. And you could tell just going outside. I mean, you could smell the smoke and things were dark. So we thought, boy, this is probably having broader health effects just because it's preventing people from physical activity, which is, of course, one of the most important things in a healthy lifestyle. So we leverage the fact that we invite essentially all our Healthy Heart Study participants to just connect up various devices. So, for example, if they have a Fitbit, we say, hey, do you have a Fitbit? Go ahead and connect it up. And so then we had a few thousand people in the Healthy Heart Study with a connected Fitbit, and then we could look back over time, thanks to these continuously recording devices where we have timestamps, see where people lived, look at particulate matter, essentially as a surrogate of when we thought people might be more or less active, more or less likely to go outside, and did indeed find that when the particulate matter was high, especially really exceeding safe levels, that step counts really went down substantially. So pointing out this kind of other downstream effect that may not be immediately evident of the wildfires. We did something similar with shelter-in-place orders and Bluetooth-enabled scales. So same thing, we asked people, hey, you got an eye health scale that's Bluetooth-enabled, please donate that data. And again, we can go back and we looked at shelter-in-place orders and found that indeed people tended to gain weight by looking at serial measurements. And the wonderful thing about these Bluetooth connections and these APIs is once that connection is forged, it tends to persist. I mean, there are sometimes app updates and things like that that can get in the way, but it's quite passive. So the participant burden is really very minimal. And that applies to all these things, the Apple Watch stuff, the Fitbit stuff, the scale stuff. They're also Bluetooth enabled. Blood pressure cuffs, for example, you do the same thing. So every time someone steps on the scale, the investigator gets that measurement. And this, even though it was just a research letter and JAMA Network Open, got a lot of attention, I think because it was so important. It was a downstream unintended consequence of public health measures that clearly were problematic, and presumably people are generally interested in things that affect body weight as well. Okay, so in the last few slides, I want to kind of hone in on this Eureka digital research platform that again is built to facilitate anyone's mobile health-based research. So Eureka can be thought of having three components to it. So there's the flexible, scalable research platform, but we also provide access to e-cohorts. So our Healthy Heart Study is one example. The COVID Citizen Science Study I'll talk a little bit about is now another. And then we have a back-end data repository where we can perform analytics, and also administrative panels sort of access to interested investigators to track what's going on with their participants if they wish. So we have an eligibility survey that's been built. We very frequently employ remote consent. We have a randomization engine. I described that a little bit in some of the N-of-1 studies. We have many validated surveys that are already coded up, as well as we can customize surveys, many device and app integrations. We leverage phone sensors, and then we have a messaging queue that can be customized and programmed to send either push notifications via an app, text messages, or email. Another way that we think about kind of breaking up Eureka is there's the participant end, the interface with research participants that can be either web or mobile app or both. There's the cloud backend, so this rests on a HIPAA compliant instance of AWS. And there's also, as I mentioned, a study team portal that can be utilized. So we use, in terms of the mobile side, one app to deliver many studies. So we don't have to, if we're running 50 studies, we don't have to do version updates individually, but it's just one app. That doesn't mean that every participant sees every study. In fact, we can design a study to be completely exclusive. So one participant, for example, would just see that study. On the other hand, if it's not exclusive and there's an interest in collaboration, we can demonstrate more than one, and we deliver content from the back end to populate those studies. Even though we have a team, and I should mention this is an in-house team of mobile app developers, web developers, designers, data scientists at UCSF. So it's not a for-profit entity. It really is meant to promote and cultivate, foster original science. There's no requirement, nor do we usually have any sort of UCSF branding there. So it can be, the branding is up to what the investigators prefer. And again, we have templates and wireframes and designs that investigators can certainly use. We can track various invitations by campaign. So we can provide a text back. So for our COVID citizen science study, we use, text the word COVID to 41411, but it can be text the word alcohol to whatever number. We can use QR codes, we can use URLs. We can also provide, if it's a multi-center study, for example, individual text backs or QR codes or URLs to each site so that we know which participant came from which site, or other different enrollment campaigns. You want to try a poster versus Facebook ads. We can do COVID-1 for the posters, COVID-2 for the Facebook ads, and again, see how they're performing and respond accordingly. We also can co-enroll with existing studies or registries or populations. And we've done this now multiple times where we, for example, either embed some unique code in an email link or in a QR code so that then later we can link things up with that existing population, or participants can be asked to enter in a manual code to provide that link. We've done this with the Framingham Heart Study. In CCS, we've done it with some other cohorts, the Childhood Health and Development Study. We're currently in the process of doing this with a American College of Cardiology NCDR registry. We've also done this with CoreNet, where that link then provides access to their EHR data, so they can then send their EHR data. So as mentioned, we can deliver studies or construct studies either as a mobile app or as a web page for those who don't have smartphones, for example, or both. And so a given individual can have a parallel experience, such as they finish, what we call e-visit. They finish some surveys that are in their queue. When they come back to the web, that will have pushed them forward accordingly. Studies can also be completely remote. We have a lot of experience with that, which has many efficiencies, but it also has its downsides, especially in terms of engagement, or they can be done in person. So this is in collaboration with some coordinator physically meeting the person, getting consent, and taking them through the instructions to download the app, or a hybrid, which we've done as I described in the past. So for example, our initial Apple Watch study was a hybrid where we had the remote healthy heart participants, but we had the in-person cardioversion patients. As also described, we already have these integrations set up. So quite straightforward to implement them. And we can also provide a fairly straightforward study if, for example, someone just wants step counts on all their participants, but they want a way to be able to bring in that data and curate that data, or home-based blood pressure cuffs, for example. As I described, we have an integration with the Cardio mobile device, Bluetooth-enabled scales, and Apple Watches. So COVID Citizen Science is kind of an exemplar study that we were able to launch very quickly after the pandemic started. We're actually now have more than 100,000 enrolled. We have, I think, more than 60,000 enrolled via PCORNet, so we will have EHR data on them. I should also mention, incidentally, we have more data on these participants than any of us have time to dive into. So if there's an interest in secondary data analyses, and it doesn't have to be COVID related. We've done some other work leveraging the fact that we ask about medical conditions and medications quite broadly, and we get time updated information. Happy to chat about that offline. But just to use this again as an example of some of the things we can provide for anyone's study. So we recognize that retention and engagement are always a challenge in any sort of research, but especially when it's fully remote. So we, for example, in COVID Citizen Science have the study blog. We share a newsletter with updates when we have a publication or things that are related to the pandemic, for example. And again, Eureka really is built to be customizable to your study. So again, happy to chat offline about that or talk a little more about the process and the question and answer. So in conclusion, regarding this notion of digital phenotyping and personal sensing as something that may be hopefully relevant beyond simply what may be a more narrow view of mobile health, but rather to see these as tools to help facilitate clinical research more broadly. Patient-centered research questions are often especially rich and the best drivers. Leveraging existing device data for analyses can be extraordinarily efficient, but also provide novel information. Similarly, leveraging the existing device data for new applications to your disease state of interest or to changing circumstances over time that may be relevant to your field. And then again, please consider using the Eureka digital research platform. Thank you very much. Happy to answer any questions.
Thanks so much, Dr. Marcus. This was a really fascinating talk. Talk a little bit more, if you would, about how we can learn more about the Eureka platform and how to use it in clinical research.
Yeah, so people can feel free to email me. I don't know, Keith, if my email address can be made publicly available widely. It's greg.marcus@ucsf.edu. I should have written it on my thank you slide. I can write it in the chat as well. But it's also, if you just Google Eureka research platform, we do have a website that is descriptive. The process would generally be to chat with, there are 3 principal investigators, myself, Jeff Olgan, and Mark Pletcher. It might make sense to chat with us. We then have essentially an intake form that just collects some information. The first question is this going to be a good use, is your research question a good use case? There is a recharge mechanism, so we do have to cover our costs, but it's substantially less expensive than it would be to kind of build these things from scratch. And it is a tiered sort of recharge thing. So the more basic, simple studies are less expensive than more complex studies. The complex studies would generally mean a brand new feature with some new technology that's never been integrated, for example.
Great. And Carrie asks, can you talk about the consent and legal information attached to use of the app? I have to imagine that given that the app can, given that one app can lead to many studies, consent must be provided for each study. How is the consent information provided, and is it tested for its plain or lay-friendly language?
Yeah, good question. So yes, for sure, consent is obtained for each individual study. They all, of course, require IRB approval. And that's usually a combination, depends a little bit on the nature of the study. So for example, if I'm conducting a study using Eureka, then I'll obtain UCSF IRB approval. We have broad UCSF IRB approval to utilize Eureka as I've described, but if you're going to do a study at Northwestern, then you would obtain Northwestern IRB approval. They need to okay the consent form, et cetera. And it is, as with any research, there's clearly a balance to strike between making sure things are understandable but not overwhelming, and also not so burdensome that it's going to completely prevent any good science from being done. So we have employed a bit of a combination. So we usually use what we call a pledge page. That's in super simple language. We don't consider that the formal consent, but we feel kind of ethically obligated to do this, where we say, we promise, to keep your data safe, to never sell your data, kind of very basic things. And then we say, you promise to be honest with your answers, to stick with the study, et cetera. Then we have more kind of conventional consent language in a scroll bar that very much looks like consent. So for people who really want to dive into the details, those details are available. Another interesting issue that arises is HIPAA consent. So, HIPAA consent generally is really permission specifically to go through one's medical records. So for many of these studies, we don't require HIPAA consent. We do have a workflow where if, for example, with PCORNet, the PCORNet sites are going to send us their EHR data, then we have a DocuSign workflow to obtain HIPAA consent.
Great. And Jessica, on a different topic, wrote, I know you mentioned insulin levels. Can you elaborate on how levels of insulin cause irregular or rapid heart rhythms?
Interesting question. So we measured in CRAVE specifically glucose levels. So we could infer insulin levels, but we did not measure insulin levels directly. It's an interesting question that we largely don't know the answer to. So there's evidence that individuals with diabetes do have a higher risk of developing atrial fibrillation. That's kind of the best studied in that arena, and that is after adjusting for things like BMI, physical activity, hypertension, and we don't understand that relationship yet. It may be related to inflammation, which we know is a risk factor for AFib, but that's an example of a sort of secondary analysis we hope to perform with these continuously ascertained data. We can look at, frankly, we can look at minute to minute, or it's maybe every 2 minutes, but it's incredibly dense data. Glucose changes as it relates to discrete premature atrial contractions, premature ventricular contractions, which to my knowledge has never been looked at before. And again, couldn't have been without these sorts of continuously recording devices.
Yeah, and then returning to a topic similar to Carrie's question about consent, Sally asks, related to consent, how does this work for those doing secondary studies with data? Is this something participants have agreed to at the outset?
So again, good question. And that's a way of saying it's complicated or it's variable. So we do in the kind of privacy and security agreement with our Eureka participants, unless a particular study has a compelling reason not to do this, they are generally consenting to being contacted for future research. And that's kind of in the spirit of what we are generally thinking of as the Eureka community and the availability of these e-cohorts, that many of these people that sign up, especially for these longitudinal registries, that part of the deal is they're saying, yep, you can contact me for future research. Now that's different than secondary data analyses of extant data, where there it's really governed by the rules of the IRB, where you can either make the case that it's just not feasible to go back and consent them all. Most of the time, the data can be sufficiently de-identified that that sort of IRB approval isn't necessarily required.
So now thinking about recruitment from a slightly different angle, we're talking about consents. From your perspective, how can wearables and tools or platforms such as Eureka promote more inclusive participation in clinical research? So thinking particularly about members of groups historically underrepresented in clinical research.
Yeah, this is a really important and major challenge, which we know that, again, even in conventional research, not utilizing these technologies, this is a challenge and a problem that we need to do a better job with diversifying the populations we're studying. And in some ways, that challenge is amplified when we're talking about some of these sometimes expensive technologies. Now, on the more optimistic side, it's been demonstrated that those with a lower socioeconomic status tend to engage with the internet more commonly with smartphones than with laptops or desktops, for example. So that's hopeful. But this can really bring to light the absence of a trusted partner. And what we have found is that having a representative, an advocate, someone that can serve as a liaison can be very helpful. So we've done some work with an investigator named Stephen Thomas, who's the head of the Center for Health Equity at the University of Maryland, and does work, for example, in barbershops that are most typically frequented by African Americans. We've done some work related to COVID citizen science where we've partnered with him to help us with that sort of recruitment. But it is an ongoing challenge. And I think, it's a place where, funding agencies, and I know PCORI has done this, will often recognize that, especially for this sort of research, that extra resources are needed, that there are additional efforts required to make sure that we're really not just focusing on the most tech savvy individuals in a way that risks our ability to extrapolate to the general population.
Great. And what do you see as really the next frontier in digital health research? What's the next area of innovative growth for research using wearables and digital platforms?
Yeah, I think there are a couple. So one you just touched on is this idea, this issue of trust and willingness and access that all kind of go together, and it's a little bit circular. So, I would hope that there might be a cultural shift in understanding the value of original research, especially when it's being conducted by scientists that are not for profit, not necessarily from the companies that are profiting by selling these products. Now, at the same time, the hope is that those companies also recognize that value. And, the huge numbers you can achieve, and this has been demonstrated in a couple of examples by Fitbit and by Apple, you can really get the most participation when you can embed invitations in the device itself, which you can only do in partnership with industry. So I think that's one sort of cultural shift that I think we should all work towards. And it's tricky because it's, on the one hand, you're emphasizing the value of the not conflicted pure scientists, but on the other hand, it's acknowledging the role that private industry has to play. And it can be a tricky balancing act, but it's one that we have to navigate. The other, which I touched on a little bit, is a buzzword these days, is machine learning. But we're just getting to the tip of the iceberg on that, and it's these types of data that are so amenable to that sort of approach. And it's really important to emphasize that there's a kind of a fairly common misconception that, oh, you got all this data, great. That's all you need. You just need more data. You need more information. And the more data you have, the more difficult it is to work with, the less wieldy it becomes. And so figuring out how to curate that data, how to make use of it, and the statistics get complicated very quickly with these repeated measures and, and clustering within individuals and those sorts of things. And this is precisely where machine learning can really have a lot of value. Usually the problem with machine learning is it's so what they call data hungry, meaning it requires huge numbers and a lot of data to make good use of the information available.
Great, thank you. It's exciting to think about these next areas of innovation. Well, seeing no other questions in the chat, and I know we're close to time, I want to take a moment to again thank you, Dr. Marcus, for sharing your research with us and for opening all of our eyes to new opportunities to use wearables and digital platforms to support data collection and participation in clinical research. And again, I also want to thank everyone attending today's session for joining us and remind you that the evaluation for the overall symposium will appear in your platform near the end of the day tomorrow. So please watch for that evaluation tomorrow. We very much look forward to your feedback, which will inform future symposia such as this one. So again, Dr. Marcus, thanks so much for taking your time to share this research with us and also raising awareness about the Eureka platform.
My pleasure. Thanks so much.